Good evening, everyone. On behalf of the National Stem Cell Foundation of Australia, welcome to the Future Medicine Stem Cells and Cancer event. My name is Tanya Ha. I'm Director of Engagement at Science in Public, where I've been looking after communication for the Stem Cell Foundation for over 10 years, so I'm delighted to be your host this evening. I'd like to begin by acknowledging the traditional owners of the lands from which we are each joining this event. I'm coming to you from the lands of the Wurundjeri people of the Kulin Nation. I pay my respects to their elders past and present and recognise any people from other First Nations who might be joining us. In 2020 alone, nearly 150,000 new cases of cancer were diagnosed in Australia. Sadly, in the same year, there were nearly 50,000 deaths from cancer. But the good news is that survival rates are improving thanks to earlier diagnosis, improvements in treatment, and the work of scientists. The National Stem Cell Foundation is a health charity with two key missions. One mission is to support the stem cell scientists doing the evidence-based research. Our other mission, and it's the reason why we're here tonight, is to provide the broader community with information about this emerging field of regenerative medicine so that they can make informed choices about their own healthcare. Tonight, you're going to hear from three scientists. One of our directors is one of them, and two are scientists whose research we're supported. The work of our panellists is paving the way for new therapies and a better understanding of cancer and other conditions. Specifically, they are Ashley Ng, who is studying how blood cancer stem cells are controlled and, how blood stem cells are controlled and how they sometimes go rogue, leading to blood cancers. We'll also be joined by Ngaire Elwood, who is researching the use of cord blood for stem cell therapies for the treatment of cancer, leukemia, and other disorders. And our third speaker is Mark Shackleton. He's using stem cells to study the origin and progression of melanoma and other skin cancers. We'll hear a short presentation from each of them shortly, and I'll ask them each a couple of questions. Later, we'll bring all the panellists together, and you'll have a chance to ask your own questions. Please write them in the Zoom chat box, and we'll get to as many as we can. Now, behind the Science in Public participant that you might see on the screen is my colleague Laura, who's providing tech support. You can send technical issues to her directly via the chat function. Also note that this evening's event is being recorded so that we can share it online at a later date. It now gives me great pleasure to introduce our first speaker. Dr. Ashley Ng is Senior Research Officer at WEHI and consultant in haematology at the Royal Melbourne Hospital and the Peter MacCallum Cancer Centre. Last year, he won the Foundation's Metcalfe Prize for Stem Cell Research. As a clinician scientist, he meets and treats the kinds of patients who might benefit from his research in the future. Over to you, Ashley.
Thanks so much, Tanya, and thank you everyone for inviting me to speak today. And so I'm going to talk a little bit about what I do and where stem cells really fit in terms of the type of research, as well as the type of treatment that we give our patients. So if I share my screen and see if this works. I'm a clinician researcher. I work at the Walter Eliza Hall Institute of Medical Research in Parkville, but I also work across the road at both Royal Melbourne Hospital and Peter MacCallum Cancer Centre. And there I actually focus on the treatment of blood diseases and in particular leukemias. And we've been using the ability of stem cells of patients for decades, because when patients come with leukemia, one of our ways that we treat our patients is with chemotherapy. And we require the chemotherapy to attack and kill the leukemia cells, but we also require the blood stem cells of the patient to be able to recover from the chemotherapy, such the red cells, which carry the oxygen in the blood, and the white cells, which fight infection, and the platelets, which stop bleeding, to recover after each of the chemotherapy doses that we give. So we've known about chemotherapy and stem cells for quite a while, and the stem cell functions in the patient's own body are what allows us to give chemotherapy the way that we do for treating these diseases. But it became apparent that chemotherapy alone can't cure all the types of diseases that we want. And some types of cancers, such as leukemias, can also develop resistance to the chemotherapy, such that the chemotherapy itself won't be able to cure them. And that means that the leukemia cells come back. And one of the things that has arisen over time is understanding how we use stem cells as a therapy. Stem cells are the therapy we can use as from the patient's own stem cells to give back to them to try and help recover the blood system after given treatment, which is too intense for them otherwise. And we give this what we call autologous stem cell transplantation. That means we can collect the stem cells of a patient, we can give them high-dose chemotherapy, and then give the stem cells back. And this is still the way that we give a type of treatment for what we call multiple myeloma. And one of the leading ways that we treat multiple myeloma still is autologous stem cell transplantation. But for the leukemia field, we also know that if we give stem cells from someone else to a patient, where we can try and use the immune system of someone else to recognize the leukemia as foreign and attack the leukemia, in some patients, we know that chemotherapy alone is not sufficient. We can use that immune system from the reconstituted stem cells into the patient to fight the leukemia, and we can bring around cures for patients who would otherwise not be cured with our current therapies. And that's what we call the graft versus leukemia or graft versus tumor effect. And bone marrow transplantation as a therapy took quite a while to develop to the way we use it now, from the original understanding of how stem cells worked as a concept in early models to how we started to use them initially for certain diseases. And over time, we've understood how best to use stem cells and the types of diseases which respond to it, such that we can now cure with allogeneic stem cell transplantation therapy for people who are eligible for transplant, about 70% of patients who would otherwise, their treatment would not work for them and the disease would come back. The way we take stem cells from patients, either to give back to themselves or from a donor to give to a patient in allogeneic transplant, are several ways we can think about it. Stem cells in an adult live in the bone marrow, and we can harvest the bone marrow, as you can see in the picture on the left, by sucking it out of the bones in an anaesthetized patient in theatre and collecting in all that stem cell-rich bone marrow. Stem cells are quite uncommon. So even if there's a large volume of cells, stem cells still form a small portion of those, but they're sufficient to be able to generate the blood system back of patients who receive the stem cells back to them. We can also, for adults, collect stem cells predominantly from what we call GCSF mobilized. And that's a cytokine discovered by Professor Don Metcalf at the Walter Eliza Hall Institute. And I'll show you in the next slide that when he was initially understanding how GCSF worked, he also looked whether stem cells were released into the blood at the same time. And he found that that was the case. So that single observation was sufficient to change the way we collect stem cells from the procedure that we did in theatre, which is fairly rare nowadays, to mobilizing stem cells with GCSF and collect them in what we call an apheresis machine, where we collect the patient's blood and return most of the blood back to them, except the stem cells that we collect specially. And Ngaire Elwood will talk a bit more about umbilical cord blood stem cells as a source of stem cells for our treatments. So this is a slide I got from Don. This is the first GCSF purified sample that was made, and it would cost about $1 million back in the day, and had to use that very sparingly for the experiments that they made. And when he was injecting those that GCSF cytokine, which they made from expressing a specific gene for GCSF, he also found that the white cells of the animal models that they used increased in number, the neutrophils, but also noted that the stem cells released in the blood. And that was the critical observation which now is used for stem cell collections the world around. Certain diseases that I was talking about for allogeneic transplants respond better than others. And the stem cell therapy that we use for our patients are very highly selected, because allogeneic transplant can be fairly effective for those diseases such as chronic myeloid leukemia, but also for acute myeloid leukemias and myelodysplastic syndromes. All these are different types of blood diseases, but as you can see that there's some types of blood diseases and other diseases which don't respond well to the immune effect of the stem cell therapy. Looking forward, however, we can also start thinking about using stem cell therapy, but genetically modifying abnormalities in the stem cells to correct them in what we call gene therapy. And some of those now have become approved by the FDA, such as gene therapy for sickle cell, thalassemia, are all coming on the horizon. And what these gene therapies do is taking the stem cells of a patient, correcting or compensating for the abnormal gene in that patient in their blood system, and giving the stem cell back, relying on the corrected stem cells to repopulate the blood system of the patient. And this is just on the verge of happening now. So, for example, for sickle cell disease, there have been trials now being done where the compensation for the sickle cell hemoglobin, which is abnormal, can actually now, in patients, reduce the amount of transfusions they need and the complications they get. And there are a number of ways that technologies are arisen now. We can modify the genetics of a stem cell to correct those abnormalities or compensate for those abnormalities, so they now become a viable way of treating these diseases in a relatively safe way. The other type of things that we can do now with genetic manipulation, not just with stem cells, and people may have heard of this now, is CAR T therapy. Rather than using stem cells as the source with genetic correction or manipulation, we can use a patient's own T cells and genetically modify those T cells to be able to recognize specific tumor proteins. So these are cellular therapies where we can direct a patient's own T cells to attack the tumor in which they have. And this is what we call CAR T therapy. And we're currently using now that as a standard of care therapy in acute lymphoblastic leukemia and non-Hodgkin lymphoma, these B-cell cancers in which we can now have this therapeutic option, which has arisen from the understanding of the stem cell and gene therapy fields. So I'll just stop there and stop my presentation.
Thank you so much, Ashley. One thing that I did want to ask is, what makes you excited about the future, given what you've seen since you started your research, or since you started your medical career? How fast is cancer treatment changing?
It's evolving very rapidly, and one of the reasons why I went into hematology as a field was the amount of research it was undergoing in understanding blood disorders, both at a fundamental level. So in my lifetime, I've seen the transformation of how we treat diseases. So I mentioned the disease chronic myeloid leukemia before, which predominantly was one of the most common ways we treated that was with allogeneic transplantation, because it was a responsive disease. But by understanding the molecular abnormalities underlying chronic myeloid leukemia, what we called a drug called tyrosine kinase inhibitor, or imatinib, has really revolutionized that treatment. So we no longer give allogeneic transplant therapy. It's very uncommon to do that now for our patients, because most of our patients can be cured with the tablet. So understanding the molecular mechanisms and understanding the biology of disease has really evolved even in the last 10, 20 years by understanding the genetics. And now that we're starting to understand how we can manipulate the genetics of cells as a cellular therapy, it's opened up possibilities for treating patients that weren't there previously.
And what's the experience like for the patient, the previous treatment versus a tablet? Because many times people refer to cancer treatment as aggressive therapy, and they call it aggressive for a reason. How is that changing?
So we're getting better at managing those aggressive therapies over time. However, it is still quite intensive. So when I treat my patients for leukemia with chemotherapy, they need to be admitted to hospital, admitted to a ward for about a month while they undergo their treatment and until their blood system recovers. The same is similar for the stem cell transplantation patients, where they come onto the ward, be given chemotherapy and or radiotherapy for the stem cells, and then waiting for their blood counts to recover in hospital for about 3 or 4 weeks. And then we need to monitor our patients and immunosuppress them so the immune system of the donor cells, which comes back, isn't too aggressive, and develop what they call graft versus host disease. That means the immune system not only attacks the tumor, but it can attack the patient as well. And that's a significant cause of morbidity or sickness and mortality or death. And so allogeneic transplantation does not come without cost or complication, such that we can expect, even from the treatment itself, a portion of patients become very sick and potentially even die from the procedure. And that's what we try and limit ourselves to, selecting the best diseases to treat and the best patients who are eligible for the treatment. And that's what we become better at. But absolutely, if we can compare that compared to a tablet, which can potentially cure a condition, I think the patients would accept the tablet much more.
Mm-hmm. Thank you, Ashley. And we'll have Ashley back again with the other panelists at the end of today's presentations after them, and have an open questions and answers. So please do think about the kind of questions you'd like to ask Ashley and other panelists, and we'll get to those later today. But it will be your chance to ask your own questions. Now, our next speaker is going to join us by phone. So Ngaire, I'll invite you to take your phone off mute. Ngaire Elwood is, Associate Professor Ngaire Elwood is Director of BMDI Cord Blood Bank and Head of the Cord Blood Stem Cell Research Laboratory at the Murdoch Children's Research Institute in Melbourne. She's also a Director of the Foundation. Now, we're using the online medium, and thank you, technology, that we can hold webinars now. However, we are still at the mercy of technology, and unfortunately Ngaire has had a blackout in her area, so she's only able to come to us via phone. So Ngaire, are you there? Can you say hello, and we'll see if we can see you or hear you, should I say?
Oh, can you hear me okay?
Yes, I can.
Hello.
Now, up to you, Ngaire. Would you prefer me to present your slides, and I don't know if you can see them on your phone or not, or would you prefer that I just pivot and ask you questions and answers to cover your research?
I can't see the slides, but if you're happy to drive them for me, we can have a go at the short presentation I put, and then you can ask me some questions. And I do apologise for this. Yeah, the power just went out just as the presentation was about to start. So anyway, we'll try pivoting with this new technology. And if you go to the second slide, Tanya, which is the one with the baby and the umbilical cord, have you got that there?
I am. Yes. So we are now seeing the slide, yes.
Great, and I'll just let you know when to move to the next one. So, yeah, thanks so much for the invitation to speak in this webinar. So when we're talking about cord blood, we're talking about all the blood that can be obtained from the placenta and the umbilical cord after the birth of the baby and the cord has been cut. And it really lends itself nicely to being collected and banked. And it was shown about 40 years ago now that cord blood is a really rich source of blood stem cells, very similar to those that are found in bone marrow. So next slide. Oh, sorry. I was waiting for mine to move forward. So there are 3 public cord blood banks in Australia, one in Sydney, our one in Melbourne, the BMDI Cord Blood Bank that was established in 1996, and the Queensland Cord Blood Bank. And in 2001, these were brought together under the umbrella of AusCord, and we work very closely with the Australian Bone Marrow Donor Registry. Next slide. As of the 1st of April this year, in our bank here in Melbourne, we have 13,500 cord blood units available for search. So they're stored and on the Bone Marrow Donor Registry. And when we talk about a cord blood unit, we're talking about all of the cord blood that can be obtained from one baby and one mother. And we have actually released, I think we're up to 597 cord blood units for bone marrow transplant. And the next slide, please.
Yes, cord blood storage now showing. Yes.
Yes, that's great. So this is just a bit of a quick snapshot of what our program looks like. So the cord blood is collected at either the Women's Hospital or Francis Perry Hospital. We have our own specially trained midwives who recruit the mums, collect the cord blood, send it to the processing lab here at the Children's Hospital. And the cord blood is processed and frozen into the bag you can see on the left and put into that canister. The canister then goes into the rack that's being put into the big cryo storage tank where it's stored at minus 196 degrees Celsius. And the slide on the right is a view of our cryo storage facility where we have 13,500 cord blood units. So next slide, please.
Yes.
So if there's so there are some key advantages of using cord blood over unrelated donor bone marrow. And because of the banks that we have, they can be readily available. We can actually have a cord blood ready for infusion into a patient, transplantation into a patient within a week or so, which is much faster than obviously working up a bone marrow donor. There's a lower incidence of the graft-versus-host disease that Ash was just talking about, which is a really nasty complication of bone marrow transplant. There's no risk to the mother or baby. There's a lower risk of viral transmission. And the absolutely best thing about cord blood is that the stem cells do not need to match a patient exactly. So there's a much increased likelihood of finding a suitable donor for a patient. Next slide.
Yes.
So patients can search our units from all over the world, and if it is a suitable unit for that patient based on the HLA tissue typing match of the patient and the cord, then we can work it up and send the cord blood unit frozen, where it gets to the transplant centre, is thawed and infused into the patient who's undergone treatment, ready to receive that cord blood unit. And so you can see from this map that we've obviously used a lot of cord blood units in Australia, but we've also shipped a lot overseas. So about a third of what we send out is used for Australian patients and about 2/3 for international patients. Next slide, please. And
yes.
The types of diseases that cord blood is being used for bone marrow transplant is, you can see from this graph that predominantly it's for the treatment of leukaemia, 66% of the units we've sent out, and this is reflected by international statistics as well. Some for lymphoma, a very low number for myeloma, but we also then have other bone marrow failure syndromes and other sort of blood disorders like myelodysplasias, metabolic disorders, immune deficiencies, and bone marrow failure, and a few just other sort of individual diseases. Next slide, please.
Yes.
So we know that cord blood also contains other cells that may be useful for new types of therapies. And this is really being borne out over the last 5 years or so, where there are now many clinical trials in progress looking at other uses for cord blood. So in particular, there's now many trials in progress using cord blood for immune therapies for the treatment of leukemia, CAR-NK types of T cells. And these therapies can be manufactured from cord blood, and there's many clinical trials, and the results have been just really encouraging. I think we'll see a lot more of these happening in the future. There's also work going into cord blood-derived immune therapies for solid cancers, not just leukemia, but other types of tumours. It's also being investigated as a therapy for neurological disorders such as cerebral palsy, stroke, hypoxic injury, and there are many clinical trials investigating this with some evidence that cord blood may be of benefit, depending on the severity and the complexity of the disease and when the patients are treated. And at our hospital, we've also been investigating cord blood to assist with heart repair, post-surgery in babies born with congenital heart disease. Next slide, please.
Yes.
And in our research group, one of our key focuses is on using cord blood to make induced pluripotent stem cell lines, or iPSCs. So what we've been doing is we've been taking a small sample of the cord blood there. You can see on the left the bags that we freeze and the little samples. We can take one of those samples, grow them in culture in the incubator with a combination of growth factors and reprogramming factors, and we can actually turn them into induced pluripotent stem cells. And what this new type of stem cell is that those stem cells themselves can actually be driven under the right conditions to become every sort of cell in your body. And so we're interested in actually storing a master cell bank of these new type of stem cell lines. Next slide, please. It's my final slide. And so public cord blood banks can play a really important role in the development of new cellular therapies. And just on this schema here, this is what we're working towards and what we've been doing. So we contact the mum and get her re-consent. We get her consent to use a bit of her already stored cord blood to make those iPSCs. And we are working towards creating a bank that people will be able to access of these cord blood-derived iPSCs. And then we will provide these iPSCs to clinical researchers who can then turn those cells into their favourite therapeutic type of cell and move towards using them in clinical trials. Next slide, please. And the collaborators that we already have on this are using iPSC-derived CAR or immunotherapy cells for the treatment of acute myeloid leukemia. We have another group looking at photoreceptor cell therapy to treat blindness, and another group looking at iPSC-derived nerve cells for the treatment of motor neurone disease. All of this is still very early stage. But certainly, you know, I think we will see this new type of therapies coming through into the clinic in the years ahead. And I will just stop there. Thank you, Tanya.
Thank you so much, Ngaire. Well done. Quick question. Because this is the question that I think I get asked by people who know that I work with the foundation. What's the difference between private and public cord blood banking?
Right. So for the public bank, people altruistically donate their cord blood to us in Melbourne. We're the public cord blood bank here, and they don't get any money for that. And they give consent for that cord blood to go into the bank and to be used for people who need treatment all over the world, wherever it may be. And it's obviously an unrelated donor product. So for private cord blood banks, people pay money to the private cord blood bank who will collect their cord blood and process it and bank it in the same way that we do, essentially. But the only people who can access that cord blood is the baby or siblings or family members of that child. And I think they pay a fee each year up to a certain number of years. And those cord blood units cannot, due to regulatory requirements, cannot be used to treat people who are unrelated to that family.
What is so it's for their use only, what's the likelihood? So what's the pros and cons? You know, what's the likelihood that your child might need their cord blood? And if it wasn't banked, and it's an international network of cord blood banking, isn't it? That do they put themselves at a disadvantage by not having private banking?
Right, great question, and I get asked this question every week by people ringing up to ask. and so the likelihood of that cord blood unit in the private bank being used is very, very low, extremely remotely, but not impossible. And private cord blood banks certainly do release cord blood units. If that child got leukemia, you would not want to use the cord blood that had been stored for itself because it's possible it contains the leukemia clone already. But you know, we are seeing through regenerative therapies, and in the future there may be a use for your own cord blood for treatment of cerebral palsy or stroke, or, you know, I guess any sort of regenerative type therapy. We're not there yet, but, you know, that may be the future. And so what I tell people is they should never feel bad if they don't bank in the private, you know, in the bank privately, because if your child did need a cord blood or bone marrow transplant, because of the network that we have around the world, they would almost certainly find a suitable match somewhere around the world. And often for the treatment of acute myeloid leukemia, for example, it's better that it's unrelated because the cord blood helps to recognise the tumour cells in that patient. And so I guess what I say to people is, if you can afford it and you know, you understand that there's a very low likelihood of the cord blood ever being used, then, you know, sure, go ahead, feel free to bank, because who knows what the future might hold. But if you decide not to bank, then not to feel guilty and concerned, because, like I said, you know, with this network, we can almost certainly find another unit around the world. And the other thing is there's a lot of research going on into using unrelated cord blood, even for regenerative therapies. So for stroke, the stroke clinical trials going on in the US, for example, they're not even matched, HLA tissue typing matched. They're looking more at blood grouping. So even those regenerative type therapies, the day will come where it doesn't need to come from yourself. So I guess that's my long-winded short answer to people who ask about that. Do you think that answers your question, Tanya?
Yes, it does, Ngaire. You know, I learned some things that I hadn't known, and I thought I was across this. So thank you so much, and thank you for persevering in challenging circumstances. Thank you, Ngaire. Our final speaker. Thanks. Our final speaker is Professor Mark Shackleton. Mark is the Director of Oncology at Alfred Health, a Professor of Oncology at Monash University, Co-Director of the Monash Partners Comprehensive Cancer Consortium, and Chair of the Melanoma and Skin Cancer Trials Limited. The Foundation is backing his research into melanoma and vitiligo through our match funding program. Over to you, Mark.
Thanks very much, Tanya. I'll just share the screen. How's that look? Okay. Great. So again, yeah, thanks so much for the invitation to talk in this evening's seminar on a topic that's very near and dear to my heart. I'm going to take a slightly different tack to the last two speakers and talk maybe a little bit more theoretical, but the influence that understanding of stem cells and stem cell biology has had on the understanding of cancer has really been profound and extraordinary in the last 2 to 3 decades. And I've been really privileged as a clinician that then moved into research and then sort of moved back into a hybrid clinical research job to oversee that period and work in 2 areas, in 2 organ systems, if you like, 2 diseases. So the breast system, from which breast cancers arise, of course, and also the melanocyte system, which melanocytes are cells in the skin that provide our skin and hair with its colour, and the origins of the nastiest form of skin cancer, which is called melanoma. So in both those diseases and in both those normal cell systems, the understanding of the role of stem cells in maintaining those tissues has advanced dramatically, although there's still a lot of work to go. But additional to that, there's been tremendous appreciations of how the way that normal stem cells functions in those tissues are actually very relevant to understanding how the cancers that arise from those tissues behave and also might best be treated. So overall, there have been, I think, 3 main domains of relevance, if you like, to the way that understanding of stem cell biology has impacted on understanding of cancers. The first one has been the increasing appreciation that at least some cancers probably arise in normal stem cells. So we think that for the most part, cancers arise in single cells, single normal cells that acquire genetic mutations, and through the acquisition of those mutations, eventually become cancerous, although that might occur in a stepwise fashion over a period of time. But there are certainly some I think really important hypotheses that have in fact been validated in many systems, that the role of stem cells in facilitating that transformation from a normal to a cancerous cell is very important. Another main domain of relevance of normal stem cells to cancers has been the really quite striking appreciation that many of the proteins that regulate normal stem cell function are frequently abnormal in cancers. So we increasingly appreciate that there are proteins, or sometimes networks or groups of proteins, who, when they become overactive or active in any way, cause stem cells to proliferate, to divide, and to expand. Pretty much every single one of those proteins, when you experimentally make it abnormal in a cell, can lead to cancer formation. In contrast, there are other proteins and groups of proteins that, when they're activated, prevent stem cell function. They stop stem cells dividing and put them into a relatively dormant state. And it's, again, almost ubiquitous that when those proteins are lost in cells, that there's a strongly increased predisposition to cancer formation. So the overlap between proteins that regulate stem cell function, normal stem cell function, and those that are abnormally regulated in cancer is really striking, and being one of the great discoveries, I think, of the last couple of decades that have led to insights that have translated to really important concepts and new concepts around cancer treatment. The other important element of aspect of cancer that's been influenced by stem cells is understanding of something called cell organization within cancers. And the hypothesis has been that there are at least some cancers that are similarly, shall we say, hierarchically organized. I'll go into the detail of this a little bit later. But there are some cancers we think that are actually quite similarly hierarchically organized, with stem cells sitting at the top of the hierarchy, and then non-stem cells on the bottom of the hierarchy. And the implications of this model have been very important, and also influenced thinking with respect to cancer biology. So at least three really important areas that I think where stem cell biology has had a major influence on our understanding of cancer. So with a bit more detail about the first one, that is the possibility that at least some cancers are thought to begin in normal stem cells. Ashley alluded to this structure, this sort of hierarchical structure of cell development, which has been best shown in the bone marrow and blood system, and which is illustrated in this particular figure here, wherein relatively rare stem cells sit atop a hierarchy of other non-stem cell types, and not only proliferate to generate more copies of themselves in a process called cell self-renewal, but also generate non-stem cells that end up comprising the bulk of the actual organ in question. And so this model is thought to be relevant to many different normal organs. The idea that stem cells, or sometimes not, if not the sort of top level stem cells themselves, but the immediate derivatives of stem cells, which are commonly called progenitor cells, the idea that those progenitor cells are the specific targets of genetic mutations that result in the formation of cancer has been actually very convincingly shown in multiple experimental contexts. And those experiments were really remarkable. So the idea was that the experimenters targeted specific genetic mutations either to progenitor cells in a particular normal tissue, or to the sort of bottom layer of cells, the more sort of non-progenitor and non-stem cells, which we call differentiated or mature cells. And quite remarkably, in those experiments, despite those cells undergoing the same genetic mutations, the only cells from which cancer formed as a consequence of those mutations were progenitor cells in those systems. And there's been multiple examples of this in different systems. And it's now really quite well accepted that it's very advantageous in the context of a cell becoming a cancer for that cell to already have activated within it some properties of stem cells. That is the ability for extensive division and proliferation. And that if the right cancer-causing mutation comes in and affects that particular cell, then it's much more likely to end up forming a full-blown cancer than if the same mutation occurs in one of the other less actively proliferative cell types. So we do think that in many cases, it's the stem and progenitor cell components of normal tissues that are the most susceptible to becoming cancerous. In the melanocyte system, which is what I've been studying for about the last 10 or 15 years, so we are gathering evidence that aspect also applies. One thing about solid organ systems, when I say solid, I'm including things like breast tissue, but also the melanocyte system in the skin, is that they're actually far less well studied and far less well understood than many of the blood stem cell systems. In the melanocyte system, so I'm actually here showing you real data from our laboratory. It hasn't actually been published yet, although it's been presented at multiple international meetings. And we've done this really cool experiment, which is called single cell sequencing, where we isolate individual melanocytes from human skin in patients that donate the skin from surgeries that they've had, and perform what's called RNA sequencing on those cells to identify populations of cells that have got similar types of RNA, similar types and levels of RNA molecules in them. And by using sophisticated computational approaches, we can basically develop a model in which we have identified what we call melanocyte stem or progenitor cells. And this is the population actually here shown on the left-hand side, which is characterized by expression of this protein, which is called NTRK2 or NTRK2. And so we think that NTRK2 positive cells are melanocyte progenitors. There are other populations we've also identified, demonstrated on the right here, that we think some of them have some stem cell features, but they're much more likely to represent mature, functioning, pigment-producing melanocytes. What we did then was to work out ways to identify and isolate the NTRK2 positive population of normal skin melanocytes, and to evaluate those cells in skin, again taken directly from patients shown there on the left-hand side, and expose that skin to ultraviolet light. Of course, ultraviolet light is the main melanoma causing agent that we're all exposed to when we walk out in the sun. And we can show, actually, we've shown very convincingly in multiple different ways, one of them shown here, that in fact it's dominantly that NTRK2 positive melanocyte progenitor subpopulation, which is the population that's dramatically activated and expands as a consequence of exposure of skin to ultraviolet light. So the same type of evidence is emerging in the melanocyte system that's been well shown in other systems that melanocyte progenitors or stem cells are the cells of origin of tumors that become melanoma and have such deadly consequences for patients. So the second aspect that I was going to mention that I talked in the first slide was how the understanding of hierarchical cell organization within normal systems, within normal organs, has influenced our understanding of how cancers are put together from a cellular point of view. And as a result of this sort of thinking in this area, researchers came up with a concept which became known as the cancer stem cell model, which is shown here on the top left. And really the idea of the cancer stem cell model just borrows directly from observations about normal cell structures within normal organs and tissues. Here is shown with the stem cell fractions in red that within established cancers are thought to sit atop cancer stem cell, if you like, cancer stem cell hierarchies, and that similar to normal stem cells, specifically proliferate to make more copies of themselves in a process called self-renewal, but can also generate other types of cancer cells that have a reduced ability to proliferate and to propagate disease in patients. And these are the differently coloured cells identified here on the left-hand side of that upper left diagram. In some models, it's proposed that the cancer stem cell fraction, these very sort of highly tumour-forming cells, are relatively rare in some cancers. Although it's true that in melanoma, we actually show that they're surprisingly frequent, and I'll come to that in a moment. And so this model has actually been very influential in getting us to think about how cancers actually behave. But although itself has been influenced by other observations, again relevant to the normal to the normal stem cell field, which have been the increasing appreciation that these states of cells being stem cells and then moving towards being progenitor cells and then moving towards being fully mature cells are actually not as sort of strictly hierarchical as was probably originally proposed. And there is certainly in many normal developmental systems, many cells do have an ability to what's called plastically go up and down those hierarchies, where a little bit more differentiated cells can become less differentiated, and also vice versa, but that process can actually flip-flop backwards and forwards. The kind of idea of plasticity or cell interconversion is also now thought to be very relevant to the way that cancers are able to maintain and propagate themselves and spread within patients. And so ultimately, and of course, underlying all that in cancers has been the increasing appreciation, really an amazing revelation, I think, of the last 10 to 15 years, enabled by extensive genomic sequencing of cancers, that there's in fact far more genetic instability within cancers than was ever previously thought, and certainly far more than we see in normal stem cell systems. So although there have been a lot of important learnings for understanding cancer biology based on the behavior of normal stem cell systems, the development of things such as the cancer stem cell and interconversion models, there are still some very important differences between cancer cells or cancer stem cells and their normal cell counterparts.
Mark, can I ask you to go through your last slides pretty quickly, because we want to have some time for questions and answers. Thank you.
This is really just to show what we've done in the melanoma system, where these concepts have only very recently been tested, including through some of our own work. Surprisingly, we actually found that there is an organization of if you like, more differentiated melanoma cells, which are the sort of darker colored cells here at the bottom of the pyramid, and also much lighter colored cells, which sit at these bulky cells that sit at the top of the pyramid. And we've in fact found in melanoma, quite surprisingly, that melanoma stem cells are very, very common. And in fact, that they're actually highly abundant. And they're particularly strongly driven by a protein called MYC, and also by inhibition of a protein called P53, which actually happen to be incredibly important proteins that are known to regulate regulate stem cells and progenitor cells in normal tissue, providing further evidence of the influence of stem cell biology and the understanding of stem cell regulation on cancers. So I'll leave it there, and I'm happy to take questions.
Thank you, Mark. And I'll invite our other panelists back to the screen so we can open up for questions and answers. And a reminder that you can put your questions into the chat box. We might go, I know we plan to finish at 7, but we might go a few minutes over to see if we can get a few more questions in there. We will, if you do have a question that you want to ask of a specific panelist, then do put their name in the chat box. I'll start off with a comment earlier that about, a mother getting treated with immunotherapy based on killer T cells in a clinic in Slovakia. And there being different treatments recommended by different people. I won't go into the details there, but I did want to ask you, Ashley, do you hear people being told or recommended with different sorts of stem cell therapies and different treatments? And what's your very general advice on what people should say when they get different recommendations?
In Australia, we're fairly one, well off, and two, good in terms of understanding what types of therapy should be applied. We apply very rigorous standards to both the therapy that we offer our patients, either in standard of care or trial, and also we're fairly heavily regulated in terms of the type of therapy that we can give based on good evidence that it either works well or it's justifiable to test in a clinical trial. So when I have, first of all, getting a good opinion from a respected clinician to understand what types of therapy being offered is always my first port of call. Getting a second opinion is always very good as well. And we actually very much encourage that as well. But there are certain trials or therapies that are offered for example, CAR T therapy, which are kind of new. And understanding how the trial has been conducted and what is actually being done is actually quite important. And whether it's been done at a respected, a reputable centre is also very important. So I think very good to ask around. If your primary practitioner doesn't know much about it, there are always places who are well versed with what's going on in terms of research and current standards of care treatments. And I would always get a good opinion so that you're comfortable with the level of expertise that you're talking to.
If you're offered a place in a clinical trial and charged for it, does that happen in Australia, or is that a legitimate clinical trial, or would that raise your eyebrows?
I would raise patients enrolled in clinical trials should not be paying to get a therapy. And for all our patients, for therapy itself, they should never be charged for it. It's something that they should be supported and be voluntary, and it shouldn't be a way that they shouldn't be asked for money to pay for a therapy.
Yeah. Now, this next question from Alan Miller, this might be one for you, Ngaire, but feel free, Ashley and Mark, to jump in. Are you still there, Ngaire? Do we still have you online, Ngaire? I think we don't have her at the moment. So either Mark or Ashley, you might know the answer to this one. Alan Miller has asked an interesting question. May I ask a question to the panel? The ethnicity of patients collected and known. Is the ethnicity of patients collected and known? And do you know what percentage of Australian patients requiring a stem cell transplant are not Caucasian? Is there a greater need for more people of First Nations heritage and other ethnicities to become stem cell and cord blood donors to meet the patient demand? And I know I've seen stories of, for example, Chinese language newspapers in Canada are putting out calls because they have a shortage of people with East Asian ethnicity. Mark and Ashley, can you comment on that?
So maybe I'll quickly say, in general, yes, we would encourage people who are voluntary donors, if they're willing and able to become either blood donor or a stem cell donor, that'd be fantastic. So if we take it away from the stem cells and just talk about blood, for instance, there are certain populations of Indigenous people or have a specific proteins on their blood, which is hard to cross-match. That means we find getting blood, if they need a blood transfusion, difficult. And that's because there's not enough donors from that population or the culture or ethnicity who actually are able to donate blood for them. And it can be hard to cross-match blood. So that's stepping away from the stem cells, but for blood donors in itself. What we do when we match donors to recipients is look at what we call HLA antigens. And these are proteins on the cell surface which help T cells, the immune cells, communicate and identify foreign proteins and interact with cancer cells. So we also know that certain HLA types are difficult to find because they aren't either related or they're not well represented from a cultural ethnicity point of view in the stem cell banks or registries. So I would always encourage that, because there are patients that we do have from a specific ethnic background, we may actually find difficult to find a matched donor available for them.
Thanks, Ashley. Now it's your last chance to ask a question, but while we wait to see if there's any more questions, Mark, I did want to ask you one, that stem cells are useful in cancer research from what I've gathered, because you're able to create living tissues in the lab in a dish so that you can test different treatments before putting it into a patient. And when we're talking about chemotherapy and other, aggressive type treatments, it might be good to work it out in the lab before putting someone through a treatment that might or might not be something they get a benefit from. Can you comment in general, like not necessarily melanoma and skin cancer, but how is that work progressing? Is that something that we can see more of in the future with personalised medicine?
Yeah, thanks. It's been one of the great, I think, enabling features of cancers is the fact that they contain these stem and progenitor-like cell populations that I alluded to just before. And those cells provide the ability of the cancer to grow and spread within patients, of course, and that's the biggest problem that we're trying to address in therapy. But the same properties that enable them to do that in patients also in many cases enable them to do that is to multiply and grow and spread when you take them out of patients and put them into plastic dishes in the laboratory. And so there are several cancers in which that can be done quite reliably. One of the best examples is actually probably cancers of the colon, cancers of the gut, where the progenitor and stem-like cancer cells seem to be particularly good at forming little sort of mini colon cancers when they're put into plastic dishes. And there's extensive work going on in different laboratories and groups across the world, and particularly a big group linked to my work here at Monash University, where and I mean, the sort of beauty of that system is that you don't actually need many cells to form an individual little tumor in a dish. So it's such that if you say isolate, a million cancer cells from a colon cancer specimen, you can actually divide them up. You can potentially put in, just say 10 or so of those cells into many, like hundreds and hundreds of individual, we call them wells in a plastic dish. And each of those little 10 cell deposits has the ability to form its own tumor. So you essentially get, 100,000 little kind of mini tumors of that particular patient's colon cancer. And then in the lab experimentally, you can sort of plop onto those tumors that they're just sitting there in a dish floating in some fluid. You can actually put into those dishes anything you like, particularly including all sorts of different types of cancer treatments, in order to try and identify which of those treatments is likely to be most effective for that particular patient. And there's a very active program at the moment going on at Monash, again, linked to colon cancer, where we're really trying to do that as much as possible in real time. One of the challenges with that is that in clinical practice, we often don't have a lot of time to make treatment decisions because patients can get reasonably sick quite quickly. And we know that we need to move fast to try and stabilize a particular person's situation. But where it's possible, if say at the time of initial surgical removal, maybe even before the cancer recurs and comes back and does require more aggressive drug-based treatment, it's certainly possible, and there's been multiple case reports about where this has been done, to identify those therapies using this sort of disease in a dish type of approach to be able to work out which of those drug therapies is most likely to be effective for that particular patient. So it's a very exciting field that many of us are interested in, and we hope will increasingly be able to be applied in real world settings, not just in the research space.
I can imagine it's really powerful for you as an oncologist and interesting as a researcher, because that means that you can select, the combination of chemo drugs or treatments that's going to have most likely have the best benefit for the patient. And also really if you can avoid giving futile treatment, which I guess if someone might only have months to live, they don't want to have, months of, poor quality of life with treatment. Very powerful and interesting work.
I think that's a super important point. The other thing is sometimes you do these experiments and you find that those little tumor organoids are very sensitive to treatments that you wouldn't have previously expected them to be sensitive to, and that are not even standardly used for patients for that particular cancer. One of the great learnings in cancer biology of the last decade or two has just been how individual every person's cancer is, and in the same way we're increasingly really thinking about individualizing treatments, and that's probably the ultimate way to individualize a treatment, is to actually test a large panel of drugs and figure out which ones work actually for that particular patient's cancer.
I might take the last question for you, Ashley, and we'll make it short, sharp and shiny. Pri has asked, how do you deal with cancer cell evolution while developing potential treatments? Is that something you have any thoughts on?
Yeah, this is a very tough area. And one of the reasons why we're still researching cancers and treating cancers decades later is that cancers have the ability to either select clones. That means part of a cancer cell, a group of cancer cells, they may not all be the same. And what Mark's work has shown, for example, you mentioned single cell sequencing or looking at different cells within a group of cancers. A cell may not be the same as the cell next to it. And that can be the same with blood cancers, where the different blood cancers have different gene mutations and different susceptibilities to our treatments. And what we can find emerging now is when we look at single cell experiments and what we call barcoding experiments, there's certain cells in the cancer which are predisposed to do certain things. So understanding that biology can actually help us understand which cells are doing what and what we need to target in those cells to try and get rid of them to prevent complications or progression of cancer, or for cancers which are predisposed to developing what we call metastasis or moving from the site. From a blood cancer point of view, we are doing a lot more what we call genomic sequencing and understanding the genetics of the cancer a lot better. For example, for leukemias, we can say that there's certain cells in leukemia with certain gene mutations that make them sensitive to specific agents that we have now for treatment, which is what we call targeted therapies. And we can actually follow our patients over time by doing genomic sequencing at different times of their treatment to try and understand how clones are selected and how clones emerge and what they mean in terms of what potential therapies are available for them, but also in terms of giving us an idea of prognosis, how they will likely respond to treatments in the future. So this is a very much evolving field and very contemporary question.
Yeah, and an interesting field of research. Like I remember one of your colleagues, Shailen Naik, was telling me that he's doing single cell sequencing because you want to know which cells, not all the cells are the same. Speakers earlier have mentioned that, and that ability to do that single sequencing that Mark talked about is he compared it to a football team, that not every player in a football team has the same abilities. By analysing the individual cells and finding the variety of it, we can understand which ones are good kickers, which ones are good runners, which ones are good defenders, and target out treatments to the weak sites accordingly and understand where the strengths are as well. So it's fascinating research. That's all we've got time for. I'd really like to thank you for your questions, and please join me in thanking our panellists, Ashley Ng, Ngaire Elwood, who's back again online and can hear us. Thank you, Ngaire, and Mark Shackleton. Now, if you or someone you know has questions about the stem cell treatments that are currently available, we do have an information resource to help you. The Foundation Guidebook, What You Need to Know About Stem Cell Therapies, can be downloaded from our website at www.stemcellfoundation.net.au. So that's well worth having a look at because it gives you a checklist on the kind of things you need to ask your GP. And I think we'll have a link to that posted in comments shortly. This is the third of the Future Medicine series of public events we're hosting. The next event will be a live event, so in person in Sydney in November. And we're going to have a different panel of experts who will discuss how organoids are changing medical research. Now, organoids are functional 3D tissue structures that are made from stem cells, and they work like mini organs in a lab, which makes them hugely useful for scientists. So there's more information about that event on our website too. And of course, while you're there at your website, if you'd like to make a tax-deductible donation to the foundation, that would be lovely. We use donated funds to provide patient and public education and to support emerging researchers. So in fact, Ashley is one of last year's winners of our Metcalfe Prize, and he received $60,000 to support his work. We also run a match funding program that supports projects that are bringing new therapies to clinical trials, such as one of Mark Shackleton's vitiligo and melanoma projects. Other scientists we've supported are working on everything from fundamental research to improving treatment for cancer, multiple sclerosis, cystic fibrosis, heart disease, diabetes, vision loss, and more. And you can read more about them on our website. And you'll see that in the chat area that there are links there, direct links that will take you to the Stem Cells Patient Handbook and also to the link to donate to the foundation. Now, if you'd like to know more about making a donation, please contact our General Manager, Graham Megan, via inquiries@stemcellfoundation.net.au. Thank you again for joining us and have a great evening.